and let us prepare for the online connection with Professor Ahmed Kharabish. Dr. Ahmed is already online with us, so we can start with him or connect him. Mr. Dallas, okay? صباح الخير دكتور أحمد، زي حضرتك.
My topic today is about the cardiac MRI, road cardiac imaging in athlete heart, and how to identify the changes of the athlete heart syndrome compared to the other differential diagnosis. As you may all know that I have nothing to disclose first, and as you may all know that recently there have been many cardiac events for the athletes on the pitch while they are exercising or while they are participating in international events. It is important to, therefore, it's important to differentiate between the athlete heart syndrome and the adaptation and the changes that occurs for the heart during the training period, and to compare and differentiate it with the other cardiomyopathies and the impact of missing the athlete heart syndrome or cardiomyopathy might lead to a false diagnosis. If it's a false and negative, this might lead to a next cardiac event or missing of a family screening in a cardiomyopathy, for example. A false positive might lead to a restriction and asking one of the athletes to stop participating in sports. So the impact of the imaging and the differential diagnosis is very high. As you may all know, there are two different types of sports at the moment. One is the trends, is the static, for example, like wrestling, weightlifting, that builds of resistance, that builds of a kind of adaptation from the heart in the form of hypertrophy, more than ventricular dilatation. For example, this is one of the professional sports or the athletes practicing weightlifting, and as you may see that on the short axis view, we could see that the hypertrophy is concentric in the form of hypertrophy between 12 and 14, and the posterior wall at 11. Function is preserved, the T1 max within normal and no apparent fibrosis on those scans. Moving to the other type of sports, which is the endurance sport, where it depends on the long term in order to increase the cardiac output and the stroke volume rather than the hypertrophy. In those type of sports, the heart adapts itself by dilatation, by increasing the cavity size in order to increase the cardiac output. As you may see here on this image, if there is no athlete, if there is no regular training, compared to the trends where there is concentric, small cavity but concentric hypertrophy, usually between 12 and 14 millimeters, and the endurance where there is a dilatation and less hypertrophy when compared to the other type of athletes. This is a footballer who had cardiac MRI. The left ventricular volume, as you may see, is dilated. It was 113 milliliter per meter squared. Function is preserved. Again, no late gadolinium enhancement, although it's sometimes accepted to see non-specific mid-wall fibrosis at the inferior or at the superior insertion points. And compared to the other case, the hypertrophy there was 13 to 14, here is 11, so it's less hypertrophied when compared to the strength or the static exercise sports. Imaging role rotates around three main domains. One is the defining the size, function, tissue characterization of the myocardium on MRI. Starting with the size, it's accepted to see some dilatation, mild to moderate, but never severe. If you see a severe dilatation, this is pathological, or there is an underlying cardiomyopathy. Mild to moderate dilatation in the endurance sports is accepted, but in strength or static sports might be also suspicious for an underlying pathology. Function, low normal or mildly reduced right ventricular systolic function is also accepted in both types of sports, but usually or in all cases we will see a normal stroke volume and no wall motion abnormality. So it's accepted to see a low normal or a mildly reduced function, but it's not accepted to see an abnormal or a very low stroke volume or wall motion abnormalities. Mapping or parametric mapping in all sports or in athletes in both types is going to be within the normal, indicating no interstitial fibrosis or no interstitial remodeling that happens or take place in other cardiomyopathies. Previously, tagging was used in order to see the longitudinal functions of the heart, but now in MRI there is the new feature tagging, which compares the movement of the pixels during systole and diastole in order to measure the global longitudinal function. And as you may see here, it's different between the athlete heart, which is completely normal, the cutoff value is 16%, and compared to hypertension or hypertrophic. And hypertrophic, it is regional because mostly the global longitudinal systolic function is reduced in areas where the segments of the cardiac segments are hypertrophied, compared to hypertension, which is mostly affecting most of the segments, but in athlete heart it's completely normal global longitudinal systolic function. Differential diagnosis, when we go through differential diagnosis, then FCM comes on the top of the list. Hypertrophy usually is more than 15 or more than 16 millimeters. Sometimes there is a positive family history, which is a very important point in areas or in imaging where there is a grade hypertrophy is 12 or 13. So a positive family history is more in favor of FCM compared to an athlete heart. Of course, we will look for the typical types of hypertrophy, whether it's an apical or asymmetrical, but the dilemma and the confusion starts when there is an unusual symmetrical hypertrophic cardiomyopathy. How to compare or how to differentiate? Of course, crypts or deep crypts or systolic anterior motion with outflow tract obstructions and secondary mitral regurgitation are in favor of HCM and not an athlete heart. Again, fibrosis at the hypertrophied segment is in favor of HCM and not in favor of an athlete heart. Atypical SCM, sometimes we need to take care of atypical SCMs because sometimes hypertrophy is not at the anteroceptive but at the anterolateral segment. Also, sometimes it's confusing with the athlete heart, but low normal stroke volume usually is encountered in those cases. Fibrosis in hypertrophied segments is in favor of FCM and not an athlete heart. Systemic hypertension, if you remember, we mentioned in the earlier slides that there are two types of sports, the strength sports, where we see the adaptation in the form of hypertrophy. Endurance sports, where we see dilatation. In hypertension, clinically there is going to be mention of hypertension on one side. The other side, hypertension usually causes both dilatation and sustained concentric hypertrophy. Sometimes there is more than mild or more than moderate reduction of the systolic function compared to the athlete, which is usually low normal or mildly reduced. Amyloid is another differential diagnosis where there is significant concentric hypertrophy. Most cases, the systolic or the stroke volume is reduced. Dilatation of the atria in the form of restrictive cardiomyopathy might be present, and of course the typical enhancement in amyloid, which is severe to the extent sometimes to subendocardial in the atrial level. Many cases of amyloid might present by heart failure. For example, in this case, this is the HASTE images, axial images showing pulmonary edema in this case. Sometimes pleural effusion, pericardial effusion might be seen also in those cases. ARBC is a very important differential diagnosis, and sometimes it's difficult to differentiate between the athlete heart syndrome and ARBC or ALBC. In athlete heart, it's accepted to see mild to moderate dilatation of the right and left ventricles, but it's not accepted to see any dyskinesia, which is the major criteria of diagnosis of ARBC, as you can see on this video on the screen. So there is the dyskinesia of the right ventricular free wall here at the right ventricular free wall. ALBC usually presents on imaging by enhancement that in the subepicardial, and usually it's along the inferior wall. Sometimes it is circumferential, similar to this case, it's circumferential, sometimes it goes to the septum, and this sign is absent in athlete heart syndrome, where there is no fibrosis detected in athlete heart syndrome. Family disease sometimes presents itself by concentric hypertrophy, but usually on the T1 maps, it's going to be, or the parametric maps, it will show a reduced values on the native T1 maps, and most likely is going to be enhancement and fibrosis as well on the later enhancements. Let's go through some of few cases in order to see how the clinical approach of those cases. This case is a footballer who presented by some XP and some ECG changes and was asked to have an MRI. The MRI, as you may see on the stinging images, shows a preserved function, a good systolic function, no dyskinesia, but a dilated left ventricle 137 milliliter per meter squared. This footballer was asked to detrain for 3 months and then to have another follow-up, but the footballer didn't, he was claustrophobic, he didn't have the MRI, he had an echo images that showed regression of dilatation, which confirms that it is an athlete heart syndrome, which confirms again the MRI findings where there was no fibrosis, T1 mass was normal. So the footballer was asked to continue training, and the changes that was seen on MRI was only due to the long-term professional training. A second case was a weightlifting, professional weightlifting, and as you can see on the singing images, there is a marked hypertrophy, and which is expected in this type of sports. A low normal or maybe mildly reduced ejection fraction, but there was one thing which was the dilatation which didn't fit in the scenario of the stance or the static exercise type. We used to see concentric hypertrophy more than cavity changes, but here both were present, hypertrophy and dilatation of the left ventricle. On the later enhancement, sorry, the resolution is not the best. The subject was a big subject, so the resolution was not the best, but as you can see, there is an area of late enhancement, maybe two areas in the apical region, and there was the argument whether this is transmural late enhancement, or is it just subendocardial, or is it subepicardial enhancement. And the dilatation was also suspicious for cardiomyopathy, so everyone was between whether this is a myocarditis on top, or is it a kind of coronary event that took place because the troponin was increased on presentation. So kindly be always mindful the T1 mass was also not abnormal, so it shows 1300, so the interstitial changes. My edema, this parametric mass was on the 3 Tesla, so 55 on T2 mass is a kind of elevated. So be mindful that sometimes some athletes are using enhancing performing materials or substance. Some of them might lead to acute coronary dissection or spontaneous dissection that heals. So the argument was about the late opinion, whether this is a myocarditis with a subepi, or is it an acute coronary event due to spontaneous coronary dissection due to the use of enhancing substances. Case 3 is just that, again, a subject who presented by some atrophy while exercising. MRI and echo ECG changes showed abnormal changes. On MRI, there is the atypical appearance, the typical appearance of asymmetrical hypertrophy of the anteroceptum of HCM. So it was diagnosed with an HCM. But what was abnormal on those MRM is that usually in HCM we would see hyperdynamic ventricles, more of a supernormal systolic function. But in this case, it was the systolic function was reduced, especially on the short axis images. When we go to the late cadaveric enhancement, this might explain why the systolic function was reduced. It's because the extensive fibrosis that sometimes take place in what's so-called the burnout myocardium due to the extensive fibrosis and HCMs. So in summary, or to summarize what we were describing during the presentation, in athlete heart, mild to moderate dilatation is accepted in endurance sports, but never severe. Low normal or mildly induced in both types of sports is accepted, but again not moderate to severe, with no wall motion abnormalities. Wall thickness is always or usually between 12 and 14. Above 15 to 16 is suspicious for HCMs, and with usually negative family histories of other cardiomyopathies. Thank you very much.
أي كومنت؟
في حد عنده أسئلة أو حاجة؟ طيب دكتور وسام الموزي اتفضل. أنا مش ما فيش حد عنده